tube. Every service carries tube tamers. Okay, make sure that you guys are trying to do using the tube tamers. Tape works well. I'm not quite sure what they mean by improvised devices. I don't think that anytime that you are dealing with the Airway improvise, so Airway and improvise should not be in the same sentence. Okay, we want to use a commercial device, tape, or if we need to, once we get that tube, let's put them in a C-collar so that we can make sure that we do not manipulate that neck and possibly get that tube to dislodge. Okay, why do we make mistakes? We make mistakes because we make intubation more difficult than it should be. And we do that because of rushing, okay? Or we do that because we do not properly set out equipment. Or we did not check our equipment before we had left our base. And now we have missing pieces or possibly damaged pieces that we should have already had checked out before we even made patient contact. Look, we don't want to rush these, okay? This is a serious medical procedure, okay? And it's something that we need to practice, and we need to continue to practice, especially when we get out into the field, right? You guys know, especially you guys working in the field, that it's not like you're going to get intubation a day, right? I think that in my time as a medic, my 6 years, I've had, I believe, we'll say right around 20 intubation attempts. Okay, not all of them were successful, right? But none of them were rushed. Okay, and yeah, there was plenty of times where, I had to just go. I tried once, right, and I knew it was not going to work. I just went to my supraglottic, right. There's no shame in that, guys. You guys are not out to prove anything, okay? And I think the big thing is that you guys shouldn't be out there to prove anything to yourselves, okay? You guys need to take a deep breath. You guys need to be advocates for your patient. You guys need to make sure that when you are intubating that you do have an extra set of hands, that yes, you do need help, okay? And that you're not rushing, okay? You lay out everything, you make sure everything is working, or you have your partners do it for you, okay? Make sure that that air is being held in that LMA. Make sure that those balloons are holding up in the king. Make sure that the pilot balloon is nice and taut so that you guys know that if that thing starts to deflate, you guys will know right off the bat, right? Even with the endotracheal tube, let's set out an endotracheal tube. Let's set out a size bigger. Let's set out a size lower. Let's get our Mac blade, right, or our Miller blade, whichever one's our favorite. And then let's get the opposite blade of what we would use for this patient as a backup, okay? And then if all else fails, let's at least get somebody that knows, or at least have it in their hands, the Crike kit as a backup airway, okay? And then suction. Man, I'll tell you a story right now. I don't like telling stories in lectures, but there was, when I was a baby medic, I forgot to bring my suction in on a call, and it was a good friend of mine on city fire that, for lack of a better term, saved my ass. We were responding to a nursing home, a local nursing home here. It's a very big local nursing home, and we had to walk quite a ways to get to the patient. The patient was projectile vomiting, well, probably more than likely a head bleed, and I couldn't control the airway at all because I forgot my suction, and I had my basic partner go back to the truck, and they got lost because they don't know how to find their way back. And all of a sudden, out of the blue, one of my buddies with the fire department showed up and had their suction. And the funny part about it is that the buddy of mine that had their suction was able to tell a similar story. So you guys will forget your suction one time. I guarantee it. One time you're going to forget it, and then you're going to walk into that patient where you, oh man, I need that suction, and you'll never forget it again. Okay? Backup plans, okay, make sure that you guys are performing good BVM. rescue airways, right? Let's do our basic simple adjuncts. Let's do NPA and OPA while we're bagging. Let's switch off providers. Okay, let's try somebody else. Let's give somebody else a go at it. Maybe try a smaller tube, right? We tried that 7.5. We missed. Let's try the 7. Better lighting. Okay. Let's not get those little lights on the laryngoscope. Although I will say the new laryngoscopes have an LED light. They're pretty cool and they're pretty bright. I gotta give it to them. And then, do we need to suction more? Do I need to clear out that airway or even deep suctioning, right, in order for me to really be able to see my landmarks? Good conditions for ideal conditions for intubation. Ideal lighting, positioning, right? You want plenty of assistance, time to prepare, gather up your equipment, make sure everything works. Option to not have to do it. Hopefully the patient has an empty stomach, which they won't. And is there a backup available? Okay. I like this slide. I like that it's called ideal conditions. There are no ideal conditions for intubation, right? We just wanted to try to do the best for our patients when it comes down to it. Ideal patients, man, somebody that is has beautiful neck mobility, in my opinion, is great. A Millipede of 1, which gives me a grade, or class 1 Millipede, which is a grade 1 Cormac and Lahane, right? Good teeth, good hygiene, right? Big open nostrils, right? I love that one, big open nostrils. And I love this one, greater than 90 kilograms, but less than 110 kilograms. Yeah, sure, okay. I don't want them too small, I don't want them too big. But an airway's an airway. We got to deal with what we get. Those could probably be the exact same ideal patients, period, right? So I guess, yeah, ideal patients for intubation. When you guys see that patient, I'd rather be in a difficult airway than a failed airway, obviously, and that's kind of similar to that concept there, all right? Yes, in reality, our patients are bubbas. They are restricted mobily in some way, shape, or another. They could be immunocompromised or have medical histories that are, medical history list as long as my forearm. And, maybe they're drunk and disorderly, I guess, or whatever. Whenever we're dealing with a patient with the airway. And again, I want you guys to keep in mind that, I'll say this again, is the fact that, remember, in paramedic land, in EMS land, period, right? I don't care if you're a medic or basic or intermediate. We lived in the crash airway, guys. Most of our airways are going to be crash airways. So that means that as soon as we get on scene, right, we are already behind the 8 ball. So we need to really have our intubation skills down, okay? Yep, they tend to look like that. That's not ideal. That's doable. It's not ideal, but it is doable. This, on the other hand, man, guys, best of luck. Okay. However, this next one really makes me upset, and we're going to talk about this one a little bit. This is after a failed ET tube. What happened here? I'll tell you what happened here is that this was a terrible intubation attempt, and they just destroyed the patient's vocal cords. This is somebody that was definitely rushed, right? Unprepared. Probably did not predict the failed or crashed airway before or while they made patient contact. After seeing this is why people like this is what gives EMS a bad name, right? And I really hope that this guy was sued, and I really hope that this gentleman or lady, whoever did the intubation, lost their license. This is completely 100% uncalled for, okay? And that goes for you guys too. If you guys are rushing, you guys do this to a patient where this patient is not going to be able to talk for the rest of their lives. They're going to have a hard time swallowing. They might have to be on a trach after this, right? They might have to have G tubes in place in order to help them feed. I hope you guys lose your license over that, to be honest with you. Okay, totally uncalled for. Don't rush. Okay, stop and think. Take a breath. It's okay. It is not your emergency. Okay, do what you got to do. Be your patient advocate. Don't cause more harm. Okay, make sure you have a backup plan, and make sure to always ask for help. Okay, you need help during an intubation period. Don't be a cowboy. Don't try to do it by yourself. It isn't worth it. All right. I never miss famous last words. I'll tell you right now. This is something that I have never said in my life. Okay, I have missed. Okay, I have missed stupendously at times. Okay, however, I have never ruptured somebody's vocal cords. Okay, because I was in a rush. All right, I have taken the time. I have breathed. I have set up my equipment. I've had my backup airways. Right, and yes, I have missed with intubation. About two to three in 100 patients cannot be intubated by standard techniques. Okay, so the good news is they're rare, but they are out there, right? People that say that they have never missed have really not done too many intubation attempts. Okay, guys, just so you know, with intubation, the odds are against you. Even if it really is a beautiful site, even if it is that class 1, grade 1 melon potty, the odds of you getting that tube are technically against you, okay? I do think that here in Bernalillo County and our educational institutions do a very good job at preparing you guys to go out there and do an intubation. And remember, guys, this could be your first call. Right, this could be your first call by yourself as a baby paramedic, fresh out the gate. And the one thing that was hit home for me in paramedic school, and I tell this to everybody, okay, while you guys are in class, okay, learning how to become medics, your partner, more than likely, is being trained right upstairs from you guys in the basic or intermediate classes, right? The services here, specifically some of our private services, you guys get hired on, you guys go through their orientation, right? You could be partners with somebody in your orientation, and they throw you the keys and they say, Carpe diem, right? And have a good day. Okay? Best of luck. Don't kill nobody. All right? We can teach you everything that you guys need to know. All right? As far as paramedicine, we can't put you in every situation that you guys are going to be in, right? But we can teach you everything that you guys need to know, and you guys are still not going to be educated at all until you guys actually hit the streets and be thrown to the wolves. Okay, so keep that in mind. You guys are going to need help when it comes to difficult patients, and that is okay. All right. What are your backup choices for your failed airways? Okay. We got a lot of them. Okay. BVM. All right. If you guys have attempted, in my opinion, this is the way I see this. If you guys have attempted an intubation for whatever reason, right, and you failed it, and you go back to the BVM, and you're able to maintain an oxygen saturation above 90%, right? I don't see the need of going back for another one, but that's me as a paramedic. Okay, I don't see a need at another attempt unless there is something severely wrong with the patient medically, where they're going to need to be intubated eventually, right? But if you guys are able to maintain that oxygen saturation above 90% at BVM, stop there. Okay. Get somebody else to help you. Have another medic on scene. Another medic right next to you, so that when you fail one, they can try something different. Okay? The Alemanian King, guys, they're perfect. They're great airways. Okay? They do the job, right? Might not be as sexy as you wanted that job to be because it's just a super glottic airway, right? Who cares? Okay? When it comes down to the fact, if I drop an LMA and somebody else drops and drops an ET tube and their patient dies and my patient lives, what difference does it make? It's an airway. All right? Again, just because you can do something doesn't mean you should be doing something. Okay? And after everything has been exhausted, all right, and this goes for skills and possibly even pharmacological, right? If that is the case, let's correct the patient. Okay, another scenario. Assuming that the patient needed to be intubated, everything looks good. You are aside. You're unable to intubate, and SAPs keep dropping and dropping and dropping. Right? What are you going to do? Okay. Once again, we are going to control the airway. BVM with NPA and OPAs. I hope I'm beating this horse to death right now, guys. Okay? I hope I'm beating this horse to death right now. If you guys mess up, it's okay. Don't freak out. Figure out how you're going to protect the airway, right? And really, one of the truest, best ways to protect the airway, as long as we can maintain SATs above 90%, is the OPA, NPA, and BVM combination. Okay? When we're talking about PEEP, all right, PEEP, your normal range is about 5 to 10 centimeters of water. They are on some BVMs. The valve can be set, right? That's what PEEP is. It's kind of a restrictive breath. It's that positive end expiratory pressure that kind of helps us stent open all of our alveoli, right? Our lung tissues and alveoli, so that when we do take that nice deep breath in again, we're kind of recruiting those alveoli for good, adequate gas exchange, external respiration, right? Make sure that we're getting a good depth. Make sure we're at a good rate. Make sure we're seeing that good, gentle chest rise, okay? We definitely need to be monitoring SATs and end tidal. And let's really kind of start looking at the patient's mentation and skin color. You know, let's see if we can get an improvement even with that, okay? If you guys do have a patient, obviously, that we don't know when they last ate, if they're unresponsive, or if they told you when they last ate, make sure that if their belly is full while you guys are bagging, more than likely you guys are filling up the stomach with air as well. Okay, so just get ready for that. Be ready to turn the patient onto their side and get ready to suction, because if their bellies are full and we are bagging them for a long time, we are going to inflate their belly, and that food's going to come up on you. Okay, rule of twos. Rule of two for ventilation. We want 2 people. Okay, 1 to ventilate, 1 to hold the mask. 2 airways at a minimum. An NPA and OPA work just fine. 2 fingers, this is to remind you, for cricoid pressure, and 2 inches of head elevation, which is what we call the sniffing position. And then 2 psi pounds per square inch are actually the minimum amount of pressures that we need in order to get air all the way down to the lungs. So we would just kind of remember that you want to just squeeze the bag just enough in order to see that good, gentle chest rise. Okay, cricoid pressure, how hard do you press, right? Do we have to do any kind of modification with children? Why does it stop gastric distension or vomitus? Okay, so let's talk about cricoid pressure. First of all, there are several contraindications for this. Really, and the big contraindication is if we believe that they have had any kind of cricotracheal injury. Okay, we don't want to be manipulating that area if we believe that that area may be injured due to a traumatic event or something. Okay. Anytime that we have somebody that is actively vomiting, we don't want to apply cricoid pressure. And anytime that we have any kind of instability in the cervical spine, because we are going to be manipulating the neck of the patient. All right. The other thing is that if we don't do this right, this can actually make intubation more difficult, especially if they have a history of difficult intubation. It's important to realize that effective cricoid pressure that effective cricoid pressure in failed intubation, like in a failed intubation scenario for greater than 10 minutes by only one assistant would appear to be an unreasonable expectation. Okay, so we don't want to be holding pressure a lot while we're trying to find that airway. We want to just get down in there real quick. We want to try to apply pressure just for a little bit to see if we can get those vocal cords to show their face to us. And if not, let's go back to the BVM, pre-oxygen our patient, and try something different. Okay.